So imagine for a second that you are building your absolute dream house.
Oh, like spare no expense kind of thing.
Right, exactly. You have hired the best construction crew in the city. You have these flawless, state-of-the-art blueprints, and, the weather is just perfect.
Sounds like a great start.
But then the trucks roll up to the site, and the beds are completely empty.
Wait, really? Just empty?
Just totally empty. I mean, there's no lumber, there are no bricks, there's no concrete. You have the entire mechanism in place to build something amazing, but you are, like, completely missing the physical raw material.
Well, the project is effectively dead on arrival, right? I
Yeah.
mean, no matter how good those blueprints are.
Exactly. And honestly, that image is the perfect way to understand the biological mystery we are unpacking for you today in this deep dive.
It really is a perfect analogy for what we're looking at.
Yeah, because we are looking at this fascinating stack of clinical guidelines, hematology reports, and regenerative medicine protocols. And we're trying to answer a very specific question.
Right, what happens to a cutting-edge therapy when a patient's body literally stops delivering the raw materials?
Exactly. And specifically for you listening, we are looking at the O-shot, which is this widely popular regenerative treatment for female sexual wellness, and how it basically collides with a highly complex blood condition known as thrombocytopenia.
It represents a really compelling intersection of fields, actually, because, on one hand, you have sexual wellness and tissue regeneration,
Right.
and on the other, you have hematology, which is just the study of blood. So the O-shot, it was developed by Dr. Charles Runels. It's designed to address female sexual dysfunction.
And the clinical protocols we're looking at today show it treating a whole host of things, right? Like low libido, painful intercourse, vaginal dryness, difficulty achieving orgasm.
Yeah, I mean, even stress urinary incontinence.
Right. And what makes it unique, based on these regenerative medicine protocols, is that it completely skips synthetic chemicals. Like, there are no pharmaceutical drugs.
None at all. It uses PRP, platelet-rich plasma.
Yeah, so the provider just draws your blood, isolates the platelets, and strategically injects that concentrated plasma into the clitoral and anterior vaginal tissues to, rejuvenate those areas.
Which brings us right to the core mission for today's deep dive.
Yes, exactly. Since this entire treatment relies completely on the healing power of a patient's own platelets, what happens if you have a baseline condition that severely lowers your platelet count?
Right. Like, can you still get the procedure? Does it even work?
So autologous therapies, treatments where your own body is essentially the medicine, they force us to confront a pretty hard biological limit.
They do, because when the donor and the recipient are the exact same person, the quality of that starting material dictates, well, everything about the clinical outcome.
Right. So to understand how a lack of platelets derails this treatment, I feel like we first need to look at what platelets are actually doing when they get injected into that tissue.
Yeah, let's break that down.
Because looking at these hematology reports, I realized my entire understanding of platelets was pretty elementary. I always just thought of them as the things that give you a scab when you scrape your knee. Like, that was it.
Yeah, I mean, hemostasis or stopping bleeding is certainly their most visible function.
Right.
Platelets are these small disc-shaped cell fragments that are just circulating in your bloodstream all the time.
Okay.
And when a blood vessel sustains damage, they activate, they change shape, and they basically clump together to form a physical plug.
The scab.
Exactly, the scab. But reading through the regenerative medicine literature in our SCAC reveals that they are actually massive biochemical storehouses.
Oh, right. The sources refer to these specific structures inside them called alpha granules, I think.
Yeah, those alpha granules are the key to this entire therapy. It's wild. When platelets are activated in the tissue, those granules degranulate.
Which means they, like, break open.
Yes, they break open and release just a massive payload of growth factors and cytokines right into the surrounding area.
So let's tie this back to our construction site analogy from the beginning.
Oh, yeah, let's do that.
If the platelets are the construction crew, they aren't just putting up the yellow caution tape and the traffic cones to stop the bleeding, right?
Right, the yellow tape is the clot.
Yeah, the yellow tape is the clot. But they are actually bringing in the bricks and mortar to rebuild the road.
That's exactly it. The proteins they release are the heavy machinery. I mean, we're talking about platelet-derived growth factor, vascular endothelial growth factor, and epidermal growth factor.
That's a lot of factors.
It is. And when these are injected into the vaginal and clitoral tissues during the O-shot, they act as these high-level chemical signals.
Like giving instructions to the body.
Exactly. They diffuse through the tissue and literally tell the dormant local stem cells to, wake up and begin cellular repair.
I want to dig into the mechanics of that repair for a second, because specifically, how a protein like vascular endothelial growth factor, or VEGF, actually changes the tissue is super interesting.
Yeah, VEGF is incredible.
Like, how does a chemical signal translate into a physical change for the patient?
Well, VEGF is incredibly potent. It specifically binds to receptors on the endothelial cells.
And those are the cells that line the inside of your existing blood vessels, right?
Exactly. When VEGF binds to those cells, it triggers them to divide and migrate, and eventually they form completely new microscopic tubes that mature into functional blood vessels.
Wow.
Yeah, this process is called angiogenesis.
So you are literally growing entirely new blood supply networks right in the tissue.
You are. And obviously, more blood vessels mean exponentially better blood flow.
Right, which makes sense for the outcomes they're looking for.
Exactly. In the context of female sexual wellness, enhanced blood flow is what creates natural lubrication.
Wait, so vaginal lubrication isn't just produced by glands?
Not entirely, no.
Hmm.
A significant portion of it is actually what's called a plasma transudate.
A plasma transudate, what is that exactly?
It's basically fluid that gets pushed out of the local blood vessels when they become engorged.
Oh, wow. Okay, so by building more blood vessels, you are literally increasing the capacity for that fluid transfer, thereby solving the vaginal dryness issue.
You hit the nail on the head. And the other growth factors we mentioned, they're signaling the production of new collagen and elastin.
Which I'm guessing is what tightens the urethral support system to help with the urinary incontinence.
Yes, that structural reinforcement is crucial for treating incontinence. So the clinical success of the O-shot rests entirely on those growth factors executing those specific biological directives.
Okay, which brings us to the math.
Ah, yes, the math.
Because based on the protocols in our source stack, it's not enough to just have, normal blood. You need a massive, highly concentrated amount of these platelets delivered to a very specific spot.
Right, you can't just inject regular whole blood and expect a miracle.
So let's talk about the centrifuge. Like, how do we mathematically get enough of them into the target tissue to force that regeneration?
Well, we have to start with the baseline numbers. In a normal, healthy adult, a standard platelet count ranges from about 150,000 to 400,000 platelets per microliter of blood.
A microliter. That's a tiny, tiny amount of liquid.
Extremely tiny.
We are talking about packing hundreds of thousands of these fragments into a volume of liquid about the size of a single grain of salt.
The density really is staggering. So when you go into the clinic, the provider draws a standard volume of blood from your arm. But like we said, injecting whole blood into the vaginal tissue wouldn't cause regeneration.
Right.
So they place that blood into a highly specialized centrifuge system, like the EMSITE platform that's mentioned in the clinical guidelines.
Okay.
And the machine spins the blood at extreme g-forces to separate it based on molecular weight.
Now, I noticed the guidelines emphasize that the centrifuge has to strip out like 99% of the red blood cells.
Yeah, that's a very strict requirement.
But why go to all that trouble? If blood is naturally full of red blood cells, why are they considered detrimental in a regenerative injection?
That's a great question. So red blood cells are phenomenal at carrying oxygen when they are inside your veins, but they are highly toxic when concentrated and injected outside of a blood vessel.
Wait, toxic? Really?
Yeah, because they contain iron and reactive oxygen species. If you inject a high concentration of red blood cells directly into clitoral tissue, those cells break down.
Oh, I see where this is going.
Yeah, they release that iron, which causes severe oxidative stress, inflammation, and even tissue necrosis.
Tissue necrosis meaning the tissue literally dies. So it does the exact opposite of regenerating the tissue. It actively damages it.
Exactly. It creates a massive inflammatory response. So the centrifuge relies on density gradients to push those heavy red blood cells to the very bottom of the tube.
Makes sense.
Then the plasma, which is mostly water, stays at the top. And the platelets get trapped in this thin, concentrated middle layer called the Buffy coat.
The Buffy coat, right. So the mathematical goal of the O-shot protocol is to isolate that Buffy coat and achieve a final platelet concentration that is like 3 to 8 times greater than your normal baseline.
Yes, meaning the clinical target is well over 1 million platelets per microliter.
Over 1 million?
Over 1 million per microliter is widely considered the gold standard for triggering a reliable therapeutic response.
Okay, wait. I have to push back on this multiplier concept for a second.
Sure. What's up?
If the centrifuge is just a mechanical multiplier, like let's say it multiplies whatever you put into it by 5,
Okay.
doesn't your starting baseline completely dictate your ending number?
Yes, absolutely.
It's like making a concentrated cup of espresso, you
Mm.
know? If you only have half a scoop of coffee beans to begin with, no matter what fancy espresso machine you use or how much pressure you apply, the resulting coffee is going to be incredibly weak.
That espresso analogy is brilliant. It perfectly isolates the biggest vulnerability in all of regenerative medicine.
Right. Because it's just math.
Exactly. The term platelet-rich plasma is completely relative.
Hmm.
Rich compared to what?
Yeah.
If your baseline platelet count is severely depleted before you even walk into the clinic, a 5 times multiplier still leaves you with a final product that is therapeutically useless.
And that realization transitions us perfectly into the central mystery of this deep dive.
The thrombocytopenia problem.
Exactly. What happens when a patient looking for this therapy has thrombocytopenia?
Well, let's define it first. Thrombocytopenia is the clinical diagnosis for an abnormally low baseline platelet count.
Okay.
And it's not a single disease, but rather a manifestation of various underlying issues.
Like what kinds of issues?
Sometimes it's a production problem, where the
Yeah.
bone marrow simply isn't manufacturing enough platelets.
Oh, got it.
Other times it's a destruction problem, like idiopathic thrombocytopenic purpura. That's an autoimmune condition where the body's immune system inappropriately tags its own healthy platelets and destroys them in the spleen.
Man, the body is so complex. So when a patient with severe thrombocytopenia seeks out the O shot, our sources outline two massive roadblocks:
Two very big ones, yes.
a complete failure of efficacy and a very severe risk to patient safety. Let's tackle the efficacy roadblock first, building on that math we just did,
Okay, so let's say a patient with severe thrombocytopenia has a starting platelet count of, say, 40,000 or 50,000 per microliter.
which is way below the normal 150,000 floor.
Way below. So when that blood goes into the centrifuge, the machine cannot magically synthesize platelets out of thin air.
Right, you're just multiplying a deeply compromised number.
Exactly. A 5 times multiplier on 40,000 only gets you to 200,000 platelets per microliter.
And you said earlier we need 1,000,000.
Right. You are still 800,000 platelets short of that 1 million mark required to trigger angiogenesis.
Wow.
So when that weak plasma is injected, there simply aren't enough growth factors to overcome the tissue's resting state. The stem cells never receive a loud enough chemical signal to wake up.
Going back to our hook at the start of the show, it's literally the empty construction trucks arriving at the site.
Exactly.
The patient goes through the time, the financial expense, and frankly, the physical discomfort of the procedure, and absolutely nothing gets built,
Right. They become what the clinical literature calls a non-responder.
which is incredibly frustrating. But the lack of efficacy is just one part of it. The second roadblock, patient safety, is arguably much more critical, isn't it?
It's massively more critical. As we discussed, the fundamental baseline job of a platelet is to form a clot and stop bleeding.
Right. And thrombocytopenia exists on a wide spectrum. But the hematology reports indicate that when we get into cases of critical thrombocytopenia where counts drop below 100,000, then 50,000, and sometimes even under 20,000 per microliter, the patient's blood fundamentally loses its ability to achieve hemostasis.
It does. They are at risk for excessive, uncontrolled bleeding from even minor bumps and scrapes.
That sounds terrifying.
It is. Now, apply that biological reality to the anatomy involved in the O shot.
Oh, wow, right.
The clitoral complex and the anterior vaginal wall are some of the most highly vascularized tissues in the human body.
Right. They contain dense networks of delicate blood vessels designed to rapidly engorge with blood.
Exactly. And the procedure requires a provider to repeatedly puncture that highly vascular tissue with a needle to deliver the plasma.
Right. So you're puncturing that specific anatomical network in a patient who lacks the biological mechanism to form a clot.
That is incredibly dangerous. It almost guarantees the formation of severe hematomas, which are these large collections of blood pooling outside the vessels deep within the tissue.
I want to explore why a hematoma in that specific area is so dangerous. Because, some people might just think, oh, it's just a bad bruise, right?
It is far from just a bad bruise. When blood continuously leaks and pools in the confined anatomical spaces of the pelvis, it creates significant internal pressure.
Because the blood has nowhere to go.
Exactly. And that pressure can compress the surrounding nerve networks, like branches of the pudendal nerve.
Oh, that sounds painful.
It is. If a nerve is compressed by a hematoma for too long, It can lead to severe pain or permanent nerve trauma.
Which completely defeats the purpose of a sexual wellness procedure in the first place.
Right. It makes things much, much worse.
Which makes perfect sense of why the medical literature categorizes severe or critical thrombocytopenia, as well as any condition where platelets are normal in number, but abnormal in function, as an absolute contraindication for the O shot.
It's a hard no.
The treatment fundamentally fails the two basic hurdles of medicine, right?
Right.
It won't work, and it actively puts the patient in harm's way.
Medical interventions always require a favorable risk-to-reward ratio. In cases of severe thrombocytopenia, the reward drops to 0 while the risk of severe complications skyrockets.
Okay, so that paints a very clear picture of the extreme end of the spectrum.
Yeah.
But since we established earlier that thrombocytopenia isn't just a binary condition it ranges from mild to severe, how do providers actually draw the line?
That's where it gets nuanced.
Right, where is the clinical threshold that separates a safe candidate from someone who is disqualified?
Clinical guidelines are vital here. The International Research Group on Platelet Injections, known as GRIPE, has published extensive consensus protocols on this exact issue to give providers a measurable threshold.
Yeah, I was reading through that. And according to our stack, the Greek consensus states that a previously investigated stable platelet count of greater than 50,000 per cubic millimeter is generally not a contraindication for a PRP injection.
That's correct.
I have to admit that number really confused me.
Why is that?
Well, you said earlier that a normal healthy floor is 150,000. Why would a medical consensus determine that 50,000 is perfectly fine? That sounds like a massive drop-off. And based on our math with the centrifuge, terrible for actual efficacy.
Your observation is spot on, and it highlights the critical difference between a safety threshold and an efficacy target.
Oh, I see.
The 50,000 mark established by GRIP is primarily a hemostatic safety floor.
Meaning it just prevents them from bleeding out.
Exactly. Hematologists generally agree that a stable count above 50,000 is sufficient to prevent spontaneous bleeding and handle minor surgical trauma like a needle puncture without causing those catastrophic hematomas we talked about.
Okay, so the guideline is basically saying it's safe to do, but it doesn't guarantee the shot will actually work to regenerate tissue.
Precisely. The provider might deem it safe to perform, but they have to heavily manage the patient's expectations regarding the clinical outcome.
Because the math still doesn't add up for efficacy.
Right. Furthermore, that 50,000 guideline comes with a massive, non-negotiable caveat.
What's that?
The underlying cause of the low platelets must be known, and it must be benign. Hematologic malignancies must be completely ruled out.
Oh yeah, the sources are absolutely adamant that the cause matters just as much as the number itself.
It really does.
If your platelets are sitting at 70,000 because of an active blood cancer, severe chronic liver disease, or systemic sepsis, those are absolute red flags.
Because systemic health always dictates local tissue response. If your liver is failing or your immune system is actively attacking your own cells, the biochemical environment of your blood is totally hostile to regeneration.
Right.
Injecting that hostile plasma into the pelvic floor is just terrible medicine.
Which leads to a very practical, actionable takeaway for you listening to this.
Yes.
If you were exploring the O shot for sexual dysfunction or urinary incontinence, you cannot treat it like a casual cosmetic appointment,
You really can't.
You shouldn't just walk into a clinic and receive an injection on day one.
The initial consultation is arguably the most critical part of the entire process.
Yeah.
Best practices in regenerative medicine, as outlined in these protocols, dictate that patients must undergo a recent comprehensive blood panel, ideally drawn within the last 3 months, before a provider even considers a PRP procedure.
Because the provider has to audit the biological inventory.
Exactly.
They have to verify the bricks are actually in the warehouse before they promise to build a house.
That's the perfect way to phrase it. A responsible, certified medical provider requires that blood work to ensure 2 things. First, that you possess the raw cellular materials required for the therapy to actually succeed.
Right.
And second, to identify any hidden systemic abnormalities that would make the needle punctures unsafe. If a clinic offers to inject your blood without reviewing your recent blood chemistry, your medical history, or your current medications, especially blood thinners, that is a massive clinical red flag.
It really emphasizes how interconnected our bodily systems are. Like, you simply cannot treat pelvic floor dysfunction or reproductive tissue in isolation while ignoring the cardiovascular and hematological systems running the show behind the scenes.
It's so true. Regenerative medicine is incredibly powerful, but it relies on a very delicate biological ecosystem. The therapy is only ever as good as the internal resources supplying it.
And that brings us right back to those empty construction trucks at the building site.
In a circle.
Yeah, the O-shot has the blueprints to rebuild sensitivity, restore natural lubrication, and strengthen the tissue to stop incontinence. But if your bone marrow can't supply the bricks and the mortar, the structure simply cannot be built.
It's just biological math.
Right. Today, we've explored the fascinating mechanics of platelet-rich plasma, the incredible signaling power of growth factors like VEGF, and why a complex blood condition like severe thrombocytopenia completely breaks the mathematical equation of autologous therapies.
It really forces us to acknowledge the current limits of using the human body as its own pharmacy.
It does. Which leaves us with a final, forward-looking question for you to ponder long after this deep dive is over. As regenerative medicine continues to explode in popularity, as the medical field shifts further away from synthetic pharmaceutical drugs and relies more heavily on our body's own cells, how will science evolve to help those whose bodies simply don't have the necessary raw materials to harvest?
It's a great question.
Could we one day see the mass production of synthetic growth factors that perfectly mimic human PRP, allowing anyone to bypass a low platelet count? Or will treatments that rely on our own blood always inherently leave some patients behind?
It's definitely something to watch out for.
It's something to think about the next time you read about the wonders of regenerative therapy. Thanks for joining us on this deep dive. We'll see you next time.